So hello everyone, welcome to our new webinar on challenges in kidney transplantation in infants. Today we are very happy that Burkhard Tönshoff from Heidelberg presents us this interesting topic. Before I introduce him, I just would like to remind you that you are muted and cannot ask questions. But you are welcome to put questions in the question box in the dashboard of this application, and we will discuss them in the end of the webinar. So, Professor Tönshoff is a professor in the pediatric and nephrology at the University Children's Hospital in Heidelberg. He's vice chairman of the Department of Pediatrics and medical director of the pediatric kidney transplantation program. He graduated from the Freiburg University School of Medicine and completed a pediatric residency and fellowship at the University Children's Hospital in Heidelberg in Germany. From 1992 to 1994, he served as a postdoctoral research fellow at the Division of Pediatric Nephrology and Department of Physiology at the State University of New York at Stony Brook in USA, with a federal Lynn research grant from the Alexander von Humboldt Stiftung. His current research focuses on various issues in acute and chronic kidney diseases and renal transplantations. He's also awardee of many different prizes and a committee or chairing different scientific steering committees, and published many high impact journal publications. So Professor Tönshoff, I'm very thankful that you are here today to give us a presentation on challenges in kidney transplantation in infants. Thank you.
Yeah, thank you, Stephanie, for your nice words. Hello, everybody. Good afternoon. Thank you for your interest in this topic, and thank you for joining this presentation on challenges in kidney transplantation in infants. So, just to give you an overview, which topics we'll talk about in the next half an hour: the overall outcome, donor selection, transplant surgery, prevention of thrombosis, fluid management, immunosuppressive therapy, some words about microchimerism, infectious prophylaxis, and specific outcome in this patient population. And here you see a 3.5 kilogram infant having received a kidney transplant from his father. So, what are the primary renal diseases in infants? Infants defined here age below 2 years. Recurring kidney transplantation, and as you know, this group makes up only a small percentage of all pediatric kidney transplant recipients, 2 to 5%, but the number increases because more and more newborns with congenital anomalies of the kidney and urinary tract survive because they are successfully dialyzed. So the number of patients, of infants requiring kidney transplantation will increase in the future. So what are the primary renal diseases? Of course, CACUT, and the congenital nephrotic syndrome, neonatal cortical necrosis due to thrombosis, and autosomal recessive polycystic kidney disease. What is the distribution of body weight at kidney transplantation in small children? These are data from the ESPN registry. Here you see the absolute number of patients. Here you see the percentage of patients. And as you can see, this body weight of 10 kilogram is more or less a watershed. Most of the infants below 20 kilogram have a body weight of at least 10 kilogram, but there are a few children registered at the ESPN registry, which have also a weight below kilogram at the time of kidney transplantation. And are these patients at risk? Yes, they are. Here you see the association of recipient age at transplantation with the hazard of graft loss. And first, of course, pubertal patients have an increased hazard of graft loss, but also infants, young children have an increased hazard of graft loss. And these are data from the collaborative transplant study in Heidelberg, showing the association of recipient age with graft survival in deceased donor kidney transplant patients. And here you see the different recipient ages and death-censored graft survival starting at the time of transplantation. You see that the very young ones, the 0 to 5-year-old, have a quite good 8-year graft survival, much better than adolescents or even young adults. But early on, they are at increased risk of losing their grafts. And here you see the graft survival starting at 1 year post-transplant. Then indeed, the very young ones have the best graft survival of all other pediatric and young adult patient groups. Comparative data. Oh, war jetzt hier gerade eine Telco. Ich melde mich morgen früh, okay? Comparative data have been obtained in the ESPN registry. Here you see the cumulative incidence curves for 5-year graft survival stratified by weight at transplantation below 10 kilogram and above 10 kilogram. And you see that the mortality and the 5-year graft loss is quite comparable in the two groups. But again, the very small ones, have an increased risk of early graft loss, and the 1-year hazard ratio of graft loss in those small children, the hazard ratio is 3.84, so significantly higher than in patients above the weight of 10 kilogram. What is the general outcome of pediatric kidney transplantation nowadays? After deceased and living related donation, what can you tell the patients how long these grafts will last? And according again to the last large database of the CTH registry in Heidelberg, after deceased donor kidney transplantation, you can expect a half-life of 19.6 years in the more recent era of kidney transplantation, and for living donor kidney transplants, you can expect a half-life of approximately 24 years in the most recent era of kidney transplantation. So coming back to the infants, what is important regarding donor selection? So we just start with the first question, and only one answer is correct. Well, what is your guess? What is your opinion? Which donors are preferable for kidney transplantation in infants? So first, donations from older living donors are not suitable for kidney transplantation in infants. For young recipients, allocation of deceased donors over the age of 5 years should be prioritized. Third possibility, for young recipients, allocation of deceased donors under the age of 5 years, small for small, should be prioritized. And fourth, donation from older deceased donors are suitable for kidney transplantation in infants. So only one answer is correct. And please enter your guess about the correct answer.
So we started already.
So Stephanie, when will the answers be displayed?
So I will give them another 30 seconds and then I show you.
But they will be displayed immediately.
Yes.
Okay.
So we have another 10 seconds. Okay, then I close the poll. And so can you see the results?
Which bottom shall I can't see them, to be honest.
Okay, so the third option, the deceased donors under the age of 5 years should be prioritized. 43% of attendees think this is the correct answer.
No, it's unfortunately it's not.
It's not. Okay,
Okay.
then
Okay.
give us the right answer, please.
Yeah, actually, option 2 is the correct answer. Yeah, and I will show you the corresponding data to that in a minute. So first, we look at the difference of deceased donor age and living donor age on outcome in pediatric kidney transplantation, again from the CD8 registry. Here you see that donors above the age of 50 years, deceased donors, here in green and purple, are associated with the worst outcome. So at least in many centers, at least in Germany, a cut-off age of 50 years is taken for deceased donors. While living donors, the donor age does not play really a role, yeah, because you can select them, you can investigate thoroughly kidney function and structure in these living donors. And as you can see, also kidneys from older donors, 60 to 69, usually in the grandparent age, are associated with very good 5-year outcome in pediatric kidney transplantation. And here you see the same data. So for living related, the age limit of 50 years does not really count, while for deceased donation, donor age above 50 years is associated with worse outcome. And these data compare the 10-year transplant survival after living donation from old donor compared to deceased donation from optimal donor, and you see still that there is a slight advantage of living donation even from older donors compared to deceased donation from standard adult donors. And the ERA EDTR registry, ESPN registry, looked which donor age is optimal for the very young ones. Here you see the Kaplan-Meier survival curves for 5-year graft survival stratified by disease donor and recipient age groups and donor source. And here for the very young recipients who were transplanted between 0 to 5 years of age. So these are the infants, which we talk about mostly today. When they receive kidney allograft from a very young donor, 0 to 5, which is small for small, this is associated with the worst survival probability, because obviously many of these grafts are lost in the first weeks and months post-transplant, according to vascular issues, to thrombosis, because obviously it's very difficult to connect small vessels to small vessels. So this is not the preferable donor age for the very young recipients. And if you transplant kidneys from very young donors, 0 to 5, to older recipients, then the survival is definitely better than when you transplant them to very young recipients. So to conclude, donation from older living donors provide excellent graft outcomes in all pediatric recipients, so you can definitely accept donor grafts from living grandparents. But for young recipients, for the infants, the location of deceased donors over the age of 5 years should be prioritized. Then we go to the next topic, which is transplant surgery. So I'm a pediatrician. I can't talk too much about surgery, but this slide is from a surgeon. So you have the typical situation. They have a large adult kidney and a small recipient, which is a typical situation, living donation from a parent, or an adult deceased donation. So at least for patients above 10 kg of body weight, an extraperitoneal approach is preferred. Simultaneous ipsilateral nephrectomy is easy, and most of the transplant centers stick to a minimal recipient body weight of 8 to 10 kg. And the right side here is preferred independently whether you receive a left or right transplant kidney, because then the distance to either to the aorta and vena cava, or to the large iliac vessels is shorter when you place the kidney into the right fossa iliaca. When you have a very small recipient below the weight of 10 kg or even smaller, then some centers prefer to place the transplant kidney into the peritoneal cavity behind the colon, because then it is easier to connect this kidney with the large vessels, or aorta and caval vein. Yeah, important topic in transplantation in small children is the prevention of thrombosis. What are the causes of graft failure in pediatric renal transplant recipients? Here are data from the NAPADEX registry, and you see that vascular thrombosis accounts for approximately 10% of all index graft failures and also subsequent graft failures. So it's an important complication which should be prevented. Katrin Buda from Zurich and Markus Walz from Tübingen recently performed an international survey on behalf of the ESPN on the current practice of antithrombotic prophylaxis in pediatric kidney transplantation. And they, from their literature research, the incidence in children and adolescents of renal graft thrombosis is definitely higher than an adult kidney transplantation. And as we mentioned already, it's a major reason for graft loss. 35% of first-year graft losses and 18% of all graft losses, according to their literature search, are due to renal graft thrombosis. So they're interested how many transplant centers perform a pre-transplant thrombophilia screening in their survey, and the results were that 94% of all respondents screened for thrombophilic risk factors, 55% in all recipients, and 39% only in selected recipients. And the main reason for screening in selected recipients were a positive family history for thromboembolic events or previous thromboembolic events in the patient himself. And these were the most frequently mentioned thrombophilia risk factors, or screening parameters. Of course, standard coagulation check consisting of quick ENR, PTT, fibrinogen, thrombin time, platelet count, protein S, protein C, protein S, antithrombin, and factor V Leiden mutation, but also other risk factors such as antiphospholipid antibodies, lupus anticoagulant, level of factor VIII, metabolic factors such as homocysteine level, protein mutation, this polymorphism, lipoprotein A, were mentioned by some centers. What did this survey find out regarding the strategy of antithrombotic prophylaxis? So there is no uniform approach, because there are just very few data. It's a topic which is very difficult to study, at least. But the most popular approach was to give initially unfractionated heparin intravenously, followed by low molecular weight heparin subcutaneously, or some centers give right away low molecular weight heparin and add aspirin orally for some certain period of time. What do we do in Heidelberg? But this is just opinion-based, not data-based. So in a standard risk patient, we apply 100 units of unfractionated heparin per kilogram body weight per day as continuous infusion for the first 7 days in case of unfavorable vascular conditions or low donor age or recipient weight, multi-vessel supply of the graft, unfavorable anastomotic conditions, or anamnestic tendency to thrombosis or thrombophilia. We administer higher doses of unfractionated heparin, 200 to 400 units per kilogram body weight per day, depending on the bleeding risk. And of course, you have always to consult the surgeon regarding this issue. And we only administer low-dose aspirin, 1 to 2 milligram per kilogram body weight per day in patients with renal artery stenosis or small lumen pole vessels. After approximately 7 days post-transplant, we switch from unfractionated heparin to enoxaparin sodium, Clexane, subcutaneously in a prophylactic dosage without anti-XA level monitoring. But you have to be aware that in patients with severely impaired renal function, this dose of Clexane has to be decreased to 50%. So another important topic in these high-risk patients is fluid management. This is at the Heidelberg protocol. So kidney transplant recipients below the weight of 20 kilogram require a high initial volume intake. So what we do, we doing the preparation pre-operatively. We already administer 10 to 20 ml per kilogram body weight per hour, usually sterofondin ISO, and we target a central venous blood pressure in this phase of 7 to 10 millimeter mercury. 7 millimeter mercury is approximately 10 centimeter H2O. And then during the creation of the vascular anastomosis and before opening the aortic clamp, you have really to target a central venous pressure of above 10 millimeter mercury, and you have to aim at a mean arterial blood pressure above 80. And this can be reached mostly only by use of catecholamines, either acrinor or suprarenin. After opening the anastomosis, there's a risk of a sharp drop in blood pressure in these small recipients and central venous pressure due to redistribution of blood volume into the transplanted adult kidney, and in this phase, maintaining hemodynamics with above-mentioned values is especially critical. Up to 2 hours after declamping, drops in central venous pressure of up to 50% can be expected, and therefore a high fluid requirement is there. You have to give at least 4 to 6 ml per kilo per hour, adjusted to diuresis, of course. Usually the fluid intake is at least 2,500 ml per square meter per day, and it is advisable also in the first 24 hours to maintain a high central venous blood pressure above 10 centimeter H2O or 7 millimeter mercury, and a mean arterial blood pressure of more than 80 millimeter mercury. And although the infant usually has a much lower blood pressure, systolic blood pressure during this early phase of 100 to 120 millimeter mercury is allowed. After 48 hours, usually physiological antidiuresis occurs due to hemodynamic adaptation of the adult kidney to the child's cardiac output. What about later on? Is it important to administer high fluid intake even in the outpatient setting during the first 6 months post-transplant? And this has been studied by the Stanford group. They optimized infant intravascular volume by nasogastric or gastrostomy tube feeding with at least 2,500 ml per square meter per day for at least 6 months. So quite aggressive fluid management in these very small infants, and compared the estimated glomerular filtration rate according to Schwarz in patients who were treated according to this protocol compared to a historical cohort which was not treated according to this protocol, and you see there was a marked difference in eGFR. So if it is acceptable for the patient and the family, a high fluid intake, even in the outpatient department, the first months post-transplant, is advisable in infants. So what about immunosuppressive therapy? This is a complicated topic. We start again with a question, and only one statement regarding immunosuppressive therapy in pediatric kidney transplantation is correct out of these 4 possibilities. So the first statement is children have a higher tacrolimus oral bioavailability but lower total body clearance compared to adults. The second statement, pediatric patients require approximately 1.5 to 2 times the dosage of tacrolimus given to adults in order to achieve similar systemic exposure. The third possible answer, infants require more intense immunosuppressive therapy than older children. And the fourth possibility, MMF is well tolerated in all infants after kidney transplantation. So from these 4 possibilities, only one statement is correct. Please make your choice.
Can choose now. Okay, I think I will close the poll in 10 seconds. Okay. So option 2 was the option with the most votes, with 57%.
Yeah, and this is indeed correct. Option 2 is the correct one. So just some data on immunosuppressive therapy. As you know, 15 years ago, the famous Symphony trial was published in adult kidney transplantation, and the main message was that a regimen of low-dose tacrolimus combined with MMF is associated with the best eGFR at 1 year post-transplant and the best graft survival. And since then, this approach was also taken over by the pediatric community. Here you see data from the most recent NAPATEX report, and you see that in the transplant era, the most recent transplant era at day 30 post-transplant, 92.7% of American centers use tacrolimus, 87.7% use MMF, and approximately 60% still use prednisone at day 30 post-transplant. And here you see data from the CERTAIN registry on European usage of maintenance immunosuppressive therapy at day 30 post-transplant, and the results are quite comparable. In the most recent years, the majority of patients received tacrolimus, MMF, and at least in Europe, initial steroids are given in 90% of patients. And the combination of prednisone, TAC, and MMF, or TAC and MMF without steroids, is the most frequently used combination in the most recent transplant era, both initially and at 5 years post-transplant. But there are some peculiarities regarding the pharmacokinetics of immunosuppressive drugs in children. Probably you know that the oral bioavailability of tacrolimus is similar in pediatric patients compared to adults, but they have a higher total body clearance than adults, probably to their higher liver weight, body weight ratio. So they metabolize, especially tacrolimus, but also MMF, more rapidly than an adult. Therefore, they require approximately 2.5 to 2 times the dosage of tacrolimus given to adults in order to achieve similar systemic exposure. But there is a significant variability in tacrolimus dosing requirements within the pediatric patient population, and more precise dosing recommendations for these different pediatric subgroups are therefore required. And here just the example of tacrolimus. What is the pharmacokinetic parameter which is important for the pharmacodynamic effect of tacrolimus? This is definitely the AUC, but it is complicated to measure. That is the reason why we estimate the AUC by measuring the G trough levels. But if a patient, like a small child, like an infant, metabolizes tacrolimus more rapidly, then the trough level is not so informative. As you can see here from old data of Guido Villa and of Dr. Kim, the correlation of the trough level C0 with the AUC is at best moderate, and therefore if you have a patient who receives very high doses of tacrolimus but does not build up decent trough level, then it is preferable really to check his AUC by a so-called abbreviated PK profile. And in Heidelberg, before in the second or third week after kidney transplantation, before the patient leaves the hospital, we perform an abbreviated PK tacrolimus profile using this algorithm for all patients, because it gives a much better estimation of tacrolimus drug exposure, especially in infants post-transplant. And there have been some data published on the target tacrolimus AUC. Of course, you have to consider individual immunological and infectiological risks of individual patients. But according to these published data in the week 1 to 4, so in the early phase post-transplant, the tacrolimus AUC of 150 to 200 microgram times hour per liter is recommended during months 1 to month 3, 120 to 150, and later than month 3, in the so-called stable phase, target AUC of 75 to 150 should be aimed for. And of course, there are specific immunosuppressive strategies, such as minimization of steroids, either by steroid avoidance, early withdrawal or late withdrawal, and also minimization of calcineurin inhibitors by co-medication with MMF or co-medication with mTOR inhibitors such as everolimus, but this is not the focus of the webinar today. So we do not talk extensively on these different strategies, just to mention that at least currently a calcineurin inhibitor-free immunosuppression is not advisable for almost all pediatric kidney transplant recipients until there are new drugs on the market which can really substitute calcineurin inhibitors. So now a few words on microchimerism. What is microchimerism? It is a bidirectional transfer of cells between mother and child through the placenta during pregnancy. And there's so-called maternal microchimerism, which means that cells from the mother transfer the placenta and reach the child. And from various experimental and clinical studies, there is evidence that maternal chimerism is associated with increased tolerance after transplantation, increased reproductive fitness, and but maybe associated with induction of autoimmunity. But interestingly, there's also fetal microchimerism, so cells from the fetus transfer their placenta and enter the circulation of the mother. And again, data indicate that this might be associated with increased reproductive fitness of the mother, increased regeneration after organ injury, but there are also some drawbacks, maybe induction of autoimmunity and increased risk for preterm delivery, abortion, and preeclampsia. So we questioned whether this maternal microchimerism might play a role for increased tolerance after transplantation in infants. And we looked at the rate of treated kidney allograft rejection in the small ones, in the infants, 1 to 4 year old, compared to older children in whom microchimerism does not play a role anymore, and looked at living donor kidney transplantation either from the mother or the father. And interestingly, if you look at the young recipients, 1 to 4 year olds, who received kidney from the mother, the frequency of treated kidney allograft rejection was much lower during the first 2 years post-transplant than in patients who received a kidney from their father. And this difference was no more evident in older children. So this at least is an indirect hint that for infants receiving kidney from their mother through microchimerism, the incidence of treated rejection is obviously lower, but this does not transfer to a higher kidney transplant survival rate. This was comparable after 5 years post-transplant, independently whether the kidney was from the mother or from the father. The same was observed in older children. So what can we say on infectious prophylaxis? Again, a very broad topic, which we can only briefly mention here. This is our Heidelberg protocol. We give cephalosporin, ceftriaxone, 50 milligram per kilogram body weight per day to all patients until the drains are removed. We give here nystatin as an antifungal prophylaxis. And of course, infants have a higher risk for CMV, EBV, and BK pyromavirus nephropathy because they are more frequently naive, seronegative to these viral infections. And especially regarding CMV, there is a possibility of a chemoprophylaxis, as you know, with valganciclovir. The current recommendations of the Transplantation Society is to give prophylaxis to valganciclovir in CMV seronegative recipients receiving CMV positive graft, CMV positive recipients receiving a CMV positive graft, and to seropositive recipients receiving a CMV negative graft and thymoglobulin therapy, because in this situation, reactivation of the endogenous CMV is sometimes observed. And of course, pneumocystis jirovecii pneumonia prophylaxis with trimethoprim sulfamethoxole for at least 6 months post-transplant is an important topic. So, which specific outcome can be observed in infants after kidney transplantation? Here are some data from our colleague Markus Weitz. He looked at outcome of renal transplantation in small infants in a matched controlled analysis, data from the CERTAIN network. This was a multi-center retrospective matched controlled cohort study on infants weighing less than 10 kilograms at time of engrafting, low weight group compared to a matched control group with a body weight of 10 to 15 kilogram, and he used data from the first 2 years post-transplant derived from the CERTAIN address tree, and he observed comparable patient and transplant survival, and also the estimated glomerular filtration rate was excellent and comparable between the low weight group and the control group, which had a higher body weight at kidney transplantation, and also the overall incidences of surgery-related complications and medical outcome measures were not significantly between these groups. So from these data, we concluded that kidney transplantation in infants is a feasible option, at least in selective centers with appropriate surgical and medical expertise. I think this is really the most important conclusion from this study, that infants are a high-risk patient population for kidney transplantation, and they should be probably only being transplanted in centers with appropriate expertise. So to conclude, kidney transplantation in small children remains challenging. and requires multidisciplinary expertise because of the potentially higher complication rate. Complication range from thrombosis of graft artery or vein, to sites difference of graft and recipient, and difficult urethral anastomosis in small children with CACOT. Furthermore, small children represent a particular vulnerable population regarding fluid and blood pressure management and immunosuppressive medication in the first weeks or months after transplantation. And there are, of course, a number of important long-term issues in infant kidney transplantation, nicely being reviewed in this review of the Finnish group in Helsinki, who have probably the most experience with these small recipients. Important long-term issues are graft function, but these children lose approximately the same amount of graft function, approximately 2 ml eGFR per year as older children. Viral surveillance, HLA antibody surveillance is an important issue. Growth, motor development, neurocognitive development, cosmetic side effects of the immunosuppressive medication, bone health, metabolic risk factors, quality of life, pubertal development, adherence to medication, especially in adolescence, and structured transition to adult care. So there are a number of other topics which we could not mention today, which are equally important, at least in the long run, for infants having received a kidney transplant. Thank you very much for your attention.
So, thank you very much for this nice presentation. We already have received some questions from the audience, and for you as a reminder, you can ask your question in the question box. So the first question is from Jens König, and he asked, what are your experience regarding the use of rivaroxaban in children at thromboembolic risk receiving kidney transplantation? Do you use this group of medication in Heidelberg?
We haven't used it. I'm aware of patients of the pediatric liver transplantation. There was a publication recently in our journal Pediatric Transplantation. So it can be used in experienced hands, and it's an interesting question. I'm not so convinced that there's really a big advantage in the early phase post-transplant compared to unfractionated heparin, which can be easily monitored. But I'm definitely interested to see more data, even systematic data, on these newer drugs.
Okay, thank you. And the next question is, what is your opinion on stratifying the immune suppressive regime, cyclosporin versus tacrolimus, depending on the EBV status of the patient? Is this approach completely old-fashioned?
Well, I mean, it's an interesting question. Newer data show that with the current tacrolimus dosage ranges, the rate of PTLD is not higher than that with cyclosporin, and the efficacy of tacrolimus, especially regarding the prevention of antibody-mediated rejection, is higher, and you have less cosmetic side effects. So we administer, and many other centers administer tacrolimus also to EBV seronegative patients which receive an EBV seropositive organ, and I'm not aware of any data that the usage of cyclosporin has a remarkable advantage in this setting, but I'm aware of this, the discussion in the literature, but I'm not really convinced that cyclosporin in this situation is better. I mean, we know from large registry data that the risk of PTLD is associated with the overall intensity of immunosuppressive therapy and not with administration of a single drug such as tacrolimus versus cyclosporine. If you give cyclosporine, you definitely have more rejection, you have more antibody-mediated rejection, and then you have to use more lymphocyte antibodies such as thymoglobulin, lymphocyte depleting antibodies, and these compounds are especially associated with the risk of PTLD. So I think one cannot give the general recommendation in patients at high risk for primary EBV infection to administer cyclosporine in this situation.
Mm-hmm. Thank you. And then we have another question from Dr. Bertacci. Could you tell us your experience with belatacept instead of CNI in children in a late switch of immune suppression because of CNI toxicity or difficult compliance?
Yeah, this is a timely question. I mean, there are only a few patients being published. Pediatric patients, adolescent patients having received belatacept. As you know, belatacept in EBV seronegative patients is associated with a higher rate of PTLD. So it is licensed only for EBV seropositive patients. We have in Heidelberg, we have treated 1 or 2 patients who were non-adherent with the standard immunosuppressive therapy, Sahanofago plus PAPA. They have published, I think, a case series of 4 or 5 patients with belatacept. But the current limitation of belatacept is that it is not really available due to production issues, and second, there is no systematic study has been performed. BMS, Bristol Myers Squibb, currently performs a switch study in adolescents with stable graft function, and this study is open to everybody who is interested. It has the capacity to perform these complicated clinical trials, and of course, we are very interested in the results, which will be available approximately in 2 to 3 years.
Okay, thank you. Then we have another question from Dr. Torres. How long do you maintain CMV chemoprophylaxis after pediatric kidney transplantation?
So we in Heidelberg give it for 3 months. There are some data in adult kidney transplantation that for high-risk patients, that is donor seropositive, recipient seronegative, valganciclovir over a period of 6 months is associated with slightly higher efficacy. But on the other hand, then the rate of valganciclovir-induced leukopenia is higher, and also so the TTS recommendations, according to the TTS recommendations, also in high-risk patients, prophylaxis duration of 3 months post-transplant is effective and sufficient in most patients. If you have a patient with a repetitive CMV problem, then you can consider switching him to everolimus. There's both clinical and convincing experimental data that everolimus has a direct anti-CMV effect. So patient where recurrent CMV viremia is a problem, then the switch to everolimus is worth trying.
Okay, thank you. Then Ruxana Shroff thanks you for your excellent overview and asks, given that in block kidneys from very young donors grow so fast, is there a case for transplanting one kidney only, so to share the kidneys between two recipients?
So, I mean, for infants, the data show that kidneys from very young donors should definitely not be transplanted to infants, and especially en bloc kidneys from young donors should definitely not be transplanted to infants because of the high risk of graft thrombosis. For older children, there are more and more data accumulating that at least for donors above the age of 2 years, it is preferable to transplant single kidneys because, as you know, there is we have a high need for donors. There is an urgent donor or organ shortness, and with kidney transplant from donors above the age of 2 years, good results have been obtained with single transplantation compared to en bloc transplantation.
Mm-hmm. Thank you. Then we have a question from Philip Vornell. Where do you start heparin infusion, in the operating theater or in the recovery unit?
No, we give the first dose of heparin is given already in the operating theater.
Okay. Then another question from Antonia Bautz. Do you never use triple therapy with steroids, everolimus, and MMF in children?
The combination of everolimus and MMF is very unusual. I'm not aware of a single patient that we have treated in that way. I mean, both agents are so-called anti-proliferative agents, and if you combine them, you really have the risk of leukopenia and neutropenia, and it has never been studied systematically. So I would not recommend CNI-free immunosuppressive therapy, except for patients who have experienced PTLD. In these patients, CNI-free immunosuppressive therapy for the first year or for the first 2 years during or after PTLD is advisable according to the current guidelines, but not CNI-free immunosuppressive therapy for the standard patient.
Okay, so we have 2 more questions. I hope it's okay to still ask them. Yeah. Perfect. So there's another question from Dr. Bonnell. Is there a preferred induction agent in infant transplantation, basiliximab, for example?
Yeah, this is a very interesting topic. I mean, there were 2 randomized prospective controlled studies in the pediatric kidney transplantation patient population performed in Europe. Basiliximab in conjunction with tacrolimus and azathioprine, and the second study was basiliximab in conjunction with cyclosporin and the MMF. And both studies did not show any effect of basiliximab on the incidence of acute rejection during the first year post-transplant. So I'm not convinced. There are no data, and there's comparable data in adults. So I do not understand why still so many centers administer basiliximab to a standard patient as induction therapy for kidney transplantation. There's clearly, in my opinion of many others, no rationale. The only rationale is when you treat the patient with a protocol comparable to the so-called TWIST protocol, which implies early steroid withdrawal after 4 days post-transplant. Then in these patients, additional immunosuppressive coverage with basiliximab is advisable, but not for the standard patient who receives tacrolimus MMF and steroids during the first 6 months post-transplant.
Okay, thank you. And then Bogdan Bulata asked, is a living donor presence of antiphospholipid syndrome, per your expertise, a firm contraindication for donation in this age group?
Antiphospholipid antibodies in the donor?
As a living donor presence of in the donor, the living donor.
This is a very complicated question. I mean, fortunately, we have our colleagues from adult nephrology who take care of the donor health. So I would refer this question to them.
Okay. Good. I think you answered all of the questions which came up. Thank you very much for your nice presentation. I don't know, have you the other slide with the announcements for the next webinars also?
Yeah, of course. Oops. This is an announcement for the next seminar.
Exactly. So we have the next
TTP.
webinar. TTP on the 22nd of November from Paul Coppo from Paris. And you can also find all other webinars from this and next year on our ERKNet website under next webinars, or you scan the QR code. Yeah. Then thank you everyone again for attending this webinar, and Burkhard, you for your nice presentation. And yeah, I wish you all a nice evening.
Okay. Thank you. Bye-bye.
Thank you.